thank you so much for sitting down and talking to me. You
Yeah.
and I have had the opportunity to sit at some tables and get to know each other, and I
Absolutely.
have grown very fond of you. So
Oh.
thank you.
Well, thank you.
All right.
Yeah.
So Amanda, how has growing up in the city of Canton shaped your commitment to health justice?
So I think, when you grow up in Canton, you don't realize when you're growing up the inequities or the disparities or anything like that. So, I think it's one of those things that you reflect back as you get older, and you actually get to serve the community where you grew up. So that's a privilege that I do have. But when I look back now and learning about, as I've learned about health justice and equity and disparities, it really helps knowing the community that I'm serving, knowing kind of where the root causes are now as an adult, and saying, okay, now I can see why certain things are happening in the community.
Yeah.
Where when you grow up, you just, you kind of know that there's groups of the haves and the have-nots,
Yeah.
and people who make bad decisions, not realizing that, that's not necessarily the full story.
Right.
So I think it helps me have a better understanding of really what is driving a lot of the inequities and the disparities in the community, and focus on making real change and not just Band-Aids.
Yes.
So that's kind of what drives me. Yeah. And it's home. And so we want everybody, it's big enough to where we have real problems.
Yep.
But it's small enough to where we can actually make a difference. And I think that's really important.
Yeah.
Yeah.
So being here gives you that commitment because these are your people.
That's correct.
It's your stomping grounds.
Yeah.
So you've led through some challenging times. You have, the opioid crisis, and you have maternal health, and you have infectious disease. How have these things made you think about prevention and justice?
So they're all kind of different. So when I started, I fell into public health. I think a lot of people do, and I started initially my career as a student right out of undergrad working for the coroner's office. And they hired me just because I could type really fast and because I knew some anatomy terms. And so I was really hired in as a transcriptionist, and I just learned kind of a lot. And as you start seeing some of the issues come through, I started, my undergrad is in biology, and so I started seeing and having an interest in the toxicology results and seeing the opiate epidemic kind of start coming through the coroner's office. And growing up in Canton, there was a drug problem, but when I was younger, which was in the 80s and 90s, it didn't hit, and we didn't have, from what I understood at the time, the deaths that just started coming through. And so that opiate epidemic, I started seeing and learning a little bit about how it started and the evolution of that, and really understanding a little bit more about, that it's not necessarily a moral failing, right? This is not people, these are not bad people. These are people who suffer from an illness. And then also in that same breath and learning about it, getting to know the community that had previously been impacted by an opiate epidemic, specifically the African American community, and hearing from them and saying, well, why is it a disease now? Because we were throwing people in jail before.
Yeah.
And that was probably my first introduction to the disparity and the inequities and how we treat populations differently. Now, hopefully a lot of that is because we know more now than we did, but I can't help but think that there's a racial piece to that. So that was probably my first experience with recognizing the injustice that we have. It's right here in Canton, in Stark County. And so working through that, the opiate epidemic, really getting a good understanding and foundation on how we got here and how we can continue to do better. Then I was hired in at the health department as an epidemiologist, and I was able to work dually in infectious disease and maternal and child health. And the infectious disease at the time was really just kind of counting cases and beans and watching for outbreaks. But the maternal and child health work was so impactful to really understanding the systemic issues that we have.
Yeah.
And also the response from people who are not in this space, and trying to explain to the community or to people that don't necessarily have any skin in the game, like, hey, this is a problem. So for instance, when we talk about maternal and child health, and we talk about specifically the infant mortality rate, the disparity is up anywhere between 2 and 3 times. The infant mortality, our black babies are dying at a rate 2 or 3 times higher than our white babies. And when you explain that to people, their first thought is, well, what are those black moms doing that's wrong? What are they doing to their babies? And you're like, wait a minute. So, and I can't say, I might have thought that, 20 years ago, but now that you know more and you know about the experiences that black women have to go through, not just while they're pregnant, and you learn about this and you hear them and you listen to them, it helps explain those disparities. And so that was another part of the work and really kind of understanding the root cause and saying, okay, what are we going to do different here? But that's probably one of my biggest challenges and driving forces is trying to help people see their that cognitive dissonance, right? I can say to somebody, here's the research, here's a cohort study, here's this, here's that, and they'll still say, well, I just don't believe it. And so where do you go from there?
Right.
And then, the other big part is COVID. And COVID was still is a lingering giant event that shaped the health department. It shaped the community that we are working with now, shaped trust with public health or mistrust. And so that's some of the work that we have to do. So I think the big part is that all of those sections, all of those initiatives, all of those issues, at the root cause, it's all driven by people.
Yeah.
And, and our response is to the people. And so really trying to make sure that that's kind of at the center of the work that we do.
Yeah. And talk to me a little bit about prevention, like the role that you think prevention plays in all of this.
I don't know. I don't know if my public health counterparts would be mad at me for saying this, but I truly feel that somehow, somewhere along the line, public health has gotten away from prevention. And, I think that public health seems to be the catch-all for anything that affects a large group of people. And I don't necessarily think that that's incorrect, but just, I don't know how many years ago it was, but the Surgeon General came out and said that parenting is a public health crisis, and because it's so stressful. And I'm like, okay, it is, but how do we as a public health system address that for parents? And I just think that sometimes we get a little bit, it's too broad, and then we lose our specificity. So I think that we could, and I can talk about this a little bit later if you want. I think that we could do an exercise in kind of getting back to our own roots and saying, okay, what does prevention truly look like in our community? Because I think one of the questions that we'll talk about is what would be my bold vision, and what if I could change something, and really getting back to how do we focus on prevention and get people to embrace that as kind of a life skill, I guess.
Yeah. And I think we talk about public health and we throw out the word public health, the public health department, public health department. But I don't think a lot of people really even know what public health is. Like, how do you define public health?
Yeah. So, I look at it as a three-tiered system. Okay, so public health is really anything that is mandated in the Ohio Revised Code that we as a health department have to do to, our primary responsibility to the community is to prevent the spread of communicable disease, primarily.
Okay.
And so we have mandated programs and initiatives that we have to do. So we have to inspect, by law, your restaurants. We have to, by law, inspect pools and tattoo shops. By law, we are responsible for maintaining and containing infectious disease. And so the community saw that on a large scale during COVID when we were quarantining and isolating. Typically, you don't do that at the scale that we did. But we've done that for 100 plus years. And so, if we have a case of tuberculosis or measles, we will isolate that positive person so they don't spread it elsewhere. And if they've been in contact with anybody, we'll quarantine those people so if they do become sick, they don't spread it elsewhere.
Right.
It's the best tool we have to prevent the spread of disease.
Right.
It got a bad rap during COVID because we did it to the nth degree. But we still do that. It's still one of the best tools that we have. So that's what public health is at its core.
Okay.
And then we have what we consider like foundational services, and those are things that any good health department would do. And so they tie back to the mandated ones. But so like that's having like, a sexual health clinic, right? So people who need to come in for testing or treatment, they can come in. The foundational is disease surveillance. So that is making sure that we have our pulse on what we expect to see in the community. And then if it's higher or lower, we do a little bit of a deeper dive and say, okay, what's going on?
Okay.
Emergency preparedness. A lot of people don't realize that health departments have since 9/11, we have created plans and systems to respond to public health emergencies. So there's a few more, but that's kind of our foundational stuff. And then we have our strategic initiatives. Yeah. And those are the things that we get to do because they're specific to our community. And so Canton City Public Health has a strategic plan, 2024 to 2027. We have 4 strategic priorities, and those are based on data from our community, input from stakeholders, and from the community. Okay. Say, where should we be spending our energy? And so those strategic priorities are access to care, addiction and recovery, the neighborhood and built environment, and food access. And so we'll work with within our programs, try to bring in additional dollars, expand programs, work with partners to move those strategic priorities forward. Okay. I think a lot of times people think the health department is a primary care service. Yeah. And I always tell people, we're here for you when you need us, but we're not going to follow you throughout your lifespan. Right. So if you need to come in for vaccines or STI testing, or whatever our clinic offers, you're welcome to come in. We want you to come in, but we're not the person to come in necessarily and follow you and be your primary care. Right. Yeah.
Right. That's a good distinction. Because a lot of times we just don't know. We talk about our health departments, but I don't think a lot of people really get it. And I think that leads to underutilization of our health department. Sure. And unrealistic expectations of our health department.
That's a good point. Yeah.
Because I have in my mind what I think you should be doing.
Well, we want to be everything to everybody, but we all know we learn this.
Yes.
You can't.
You can't.
And it's very hard because Canton does have its challenges. Yeah. From a public health, and as you learn about the disparities and you learn about these systemic issues that lead to this, it all is intertwined. The social determinants of health, and I can't expect somebody to, prioritize their health if they don't have somewhere to live. Right. So I really need to help our agencies that are leading that effort to find housing and stable, affordable, and quality housing for people, because I know that can help lead to better health outcomes. Right. And so it is one of those things where we have to rely on our partners so much, but we're there to help support them in any way that we can. And we've done that through some innovative grants and things like that. Yeah.
And that's that Maslow's hierarchy of needs, right? We have to meet those basic needs. Amanda, you all have a lot of great programming and things that you're doing. Do you find that, and with you talking about like coming alongside the agencies that are in the community to help support the mission, do you find that as like agencies and community appropriately attempt to partner with you or to communicate with the health department to bring you alongside as that advocate and that community partner?
Yeah, that's a good question. Being newer in the field, I probably have not had an opportunity to explore like new innovative partnerships. Yeah. But I do think that we've always had good, strong partnerships with the partners that we do have. Yeah. But I'm sure there's people we're missing. Yeah. I think that, again, to your point, what I find is that people don't realize the scope of the work that the health department does do. Yeah. And so, when you talk about dollars, we're about a $9 million, almost $10 million agency for the city of Canton. We have 70 employees. I think we're the 3rd largest city agency out behind police and fire, maybe the 4th now, I'm not sure. But people don't think huge. About that. Yeah. People think about the health department based on the services that they need. Right. But we'll hire people in and they'll say, oh, I didn't know the health department did all this. And true story, I'll tell you, when I was at the coroner's office and I finished my degree, in my brain, the only thing I really understood about a health department was that they did death certificates because that's all I knew.
That's what you did.
That's all I knew. I did death certificates all day long. And so I remember when I was looking for a position, I was almost talked out of ever working for a local health department. Really? Because I wanted the big shiny, I wanted the policy, I wanted to change the world. And so it wasn't until I kind of started talking to some folks and in a position of data, which you and I both love data.
Yes, we do.
And I thought, oh, this will be really good. But it was just I had to do a little bit more because my perception, my reality was they did death certificates, and I think I'm in, and it's been 10 plus years, but so
Awesome.
it's just what you know. So I think we can definitely pour more partners in. The fiscal landscape, the federal fiscal landscape is changing.
Yeah.
And it's frustrating, but I'm always challenging my team to think about it as a way to get back to that maybe prevention. Like what is our mission and what's going to be new.
Yeah.
So is there we might lose some programming. Yeah. And that is just the reality because I don't make money, I spend money.
Yes.
So if the grants aren't there, then I have to find grants that are. And I'm trying to look at it as a positive and say, okay, maybe it is an opportunity for us to bring in more prevention, more chronic disease, maybe something for our older population because we don't do a lot of that. So, and I think with that will be opportunities to do additional partnerships and build some new partnerships.
Awesome. And we as community leaders have to do a better job at reaching out to you and saying, Amanda, is this a fit?
Yeah.
Can we work together on this? And so we've been talking about COVID. We talked about COVID a little bit.
Sure.
And I know that you had the opportunity to lead communication during COVID.
Well, I actually did. I actually led the epi response.
Epi response.
Epidemiology.
Okay.
Yeah. So
okay.
I did work really closely with our communications team. So I'm happy to talk about, some of that. Our communications is tied up in our emergency preparedness.
Okay.
Crisis communication, emergency preparedness. Our PIO manages that, and then her and I worked really closely together.
Okay.
So we can
so
talk about it.
when you say epi, let our listeners know what that means.
Yeah, so an epidemiologist or epidemiology is the study of the prevalence and incidence or distribution of diseases or other chronic illnesses or any public health issues. So we have a maternal child health epidemiologist at the health department, and so he's able to look at different conditions and data around maternal and child health, birth outcomes. And then we also have an infectious disease epidemiologist who does our surveillance on infectious disease kind of 24/7 around the clock.
Okay.
So we study this data that comes into us and we watch for changes.
Okay.
And if there's a change, then we say, okay, what's going on?
Right.
So it's kind of like, I always say it's kind of like, police surveillance. We're just watching you until something happens, and then we have to do something.
Right.
And we're able to put out reports to the community. We have, in the last couple of years, we've done annual STI reports, updates for our jurisdiction as well as all the other three health departments. We have a COVID and respiratory dashboard. We also have a syphilis dashboard. So over the last couple of years, we've had a significant outbreak of syphilis in our community. And so we thought, what better way to help bring awareness to that besides the billboards that people see out there.
Right.
But we have a dashboard that you can go on and you can watch the trends, up and down, who's being impacted the most, what we cover a 9-county region with that work. So that's a lot of the work that our epidemiologists do. And then they try, once you have the data, right, that's the metrics, we try to figure out the why, the who, the what, the where, so that we can put programs. And all of that data informs the work that we do.
Awesome.
Yeah.
And you talk about these dashboards. Like, how can community members access those? This is what I always talk about, the wealth of resource that's in our community that we don't even tap into. Like, how can we, I access them, but how can others know how to access those dashboards?
So I would first say, feel free to call us, right? Okay. So the dashboards are interactive online. So you do have to have access to the internet and online. Some of the other reports are online, but they're also paper, and we'd be happy to send them out, email them. But if you go to cantonhealth.org, there's a section on there that says, at the top we have we just redid our website, and we have 3 sections. One is on a healthy you, another one is on healthy communities and healthy family, and the other section is on data and resources. Okay. Go to the data resources tab, and you can scroll down, and there's a section there that says community reports. Yeah. And all of that is going to be there for you.
That's awesome.
Yeah.
Data-driven decisions. And I think a lot of times as community leaders, we don't do enough of that. We are mission-led, so our heart kind of says, I want to fix this.
Yes.
or I want to do this because
Yes.
my passion is
Yes.
in this space,
Yeah.
right? But the data may not be telling us. And that's one of the things that I've really grown to respect and admire about you is the fact that you're very intentional. And I know that your intentionality comes from the fact that you know the numbers. You know the numbers.
Yeah.
Yeah.
Well,
yeah.
when you get in this space, and I think another thing too, as a health commissioner, I came from the epi space, and then I was a director, and I was over our section that had epi in it. It also had our national accreditation work. That was part of that was quality improvement, which is all data informed, performance metrics, all data informed, and then even our workforce was in there, and that's all data informed too, because our workforce work that we've recently stood up is about identifying the gaps.
Okay.
Where do we need, and it's all based on. What positions do we need based on the need, and what is informing that. And then also, from a staff standpoint, what do we need to make sure that they are, I don't want to just say happy, but they're fulfilled.
Yeah.
And they're satisfied with the work that they're doing and with the agency they're working for. Right. So that's all data.
Yeah,
right?
it is.
And so, but when I came into the health commissioner role, there's 7 other departments that I'm not an expert in. And so I think one of the things was they have to show me where they're coming from based on some of that data, right? And so all of my directors have been there longer than me. And so that was something where I definitely had to rely on their expertise, but I also was able to say, well, show me what that looks like.
Yeah,
So,
yeah. So I want to ask something that I didn't plan on asking, but I need to call attention to this.
Oh, boy.
You are the first female health commissioner. What is that like? So what, and you may not have an answer for this right now because you're what, 2-3 years in, but like, how do you think, what's up with that? Like, what is it like to be in that space and doing this work that you're trying to do? And
so I guess I'm the first female health commissioner for the city of Canton. So
right.
in 175 years, they've never had a female health
See,
commissioner.
that should not be, I'm looking at that should not be a first,
That's
Meg,
right.
Come on.
And so I have a couple theories behind that.
Okay.
And we'll talk about that after but
Okay.
I will say, in my experience, there are a lot of other female health commissioners that are fantastic and have really been able, yes, and they've reached out to me and they're wonderful. So I'm not doing it alone. So that's really good. I would say I've never been in a position of this magnitude, I guess. I would say that it's difficult. I think not so much the woman part, but I think people think I'm younger than what I am. And I think they don't recognize my 20 years of experience necessarily in public service.
Yeah.
And I don't necessarily think that they look at me as an expert in public health. Not people in public health, but just some of the people that I interact with. And so that's a challenge that I kind of have to work with. And other than just like slamming on the table and being like, I'm not a child, it's really the only, it's time.
Yeah.
It's time and performance and me showing up and saying, here's what I can accomplish.
That's right.
So I've had good support from the city, really kind of trying to figure out the relationship. So a lot of people, I guess that they don't realize we get a lot of support from the city, but the health department is very similar to the school district.
Okay.
So we have a board, and just like the school district, they're the City of Canton School District. We are the City of Canton Health Department or Canton City Public Health, but we're managed by a board also.
Okay.
And in the Ohio Revised Code, we're a separate political subdivision from the City of Canton. So that we have a board. The board's appointed by the mayor, and then I report to the board. And the reason being, is that the decisions that a board of health should make should be separate from any political influence. Right. And if the board of health has to make a decision that is in the best interest of the health of the community, it needs to be able to do so without any of that. So that's how it's written in code. And so, so I get to, we have a board meeting tonight. It's a public meeting. Anyone's welcome to come. We don't really get a lot of people popping into the board meetings.
Right.
But yeah, so I think that that's something that a lot of folks don't realize. But we do lean on the city quite a bit because we use a lot of their services to support the work that we do.
Right.
So it's a good partnership there.
Amanda, what does health equity look like to you? You know, just you can say from the vantage of your role with public health, just in general, what does health equity look like to you?
So short answer is getting the people who need, getting people what they need.
Yeah.
Right. So this health equity, as you know, has kind of been under attack for the last year-ish.
Don't get me started.
Or more, but truly under attack. And so as a government agency, we are bound by the executive order that came out that said that, you know, we can't have health equity programming as it violates the discriminatory language. And so for us, it's less of an issue, and I'll tell you why.
Okay.
And this is because the health department and city agencies are all civil service.
Yep.
So that executive order came out in the way that I interpret it, and I'm not an attorney, but that it's very focused on hiring.
Okay.
Okay. So I think that there is a misunderstanding of health equity on, you know, the federal administration's standpoint, but they're very focused on the hiring aspect of it.
Okay.
Okay. So we have civil service. So if somebody applies for a job at the health department, they have to go through a civil service, and people get ranked based on how well their qualifications meet the job description. Is there bias built in there? I'm sure there is, but it's less bias than somebody just looking at a resume and saying, you know, having their bias inform their next step.
Right.
So when somebody interviews with us, I get a list of the top 10 people based on a numerical ranking that they have. Okay. And that ranking is based on how well their resume or the conversation that they have with the civil service department meets the minimum criteria.
Okay.
And then people get ranked. And so then I get the top 10 folks. So then I can interview and hire based on that. So the executive order doesn't impact my processes of hiring.
Okay.
At that point. What I focus on is health equity is where am I going to do my work? Yeah. And I don't think the executive order addresses that. So, you know, we've talked about this before. At the core of what we do, we use data to inform the populations that have poor health outcomes, and then we put resources there. That is equitably delivering resources to who needs them.
Absolutely.
We can do that all day, every day. That is public health in action.
Okay.
Right? So if I'm looking at a population of moms, and I see in a zip code that they have poor birth outcomes, maybe their low birth weight is higher than a zip code over here, all of my resources are going to go over here because they need it. Yeah. Right? Yeah. And so to me, that's health equity.
It is.
And we'll continue to do that.
Love it.
Yeah.
Love it. If you were going to develop a bold 3-year plan, what would you prioritize?
This is a great question. So we have our strategic plan. But if I got to do an Amanda Health Department plan.
I want an Amanda one.
Yeah, yeah. So I think that I would focus on working with the community to build trust back in their local public health system. Okay. And I don't know what that would look like, right? So I want to say, what is it that you need from us? Right. What can we do to help you start to begin trusting us? You know, I always tell the community that the people at the health department are the people that live and work and play in your community.
Absolutely.
You know, we are not necessarily influenced by whatever's happening elsewhere, you know, and we want to just deliver good services, and we want people to have good health. Yeah. You know, and it's because the people that work there are from here. They, like I said, they live and work here, and it's not some giant conspiracy to, you know, come out with a different outcome. Right. We just really want people to be able to prioritize their health, and we understand that there are many, many things that have to happen before that, but we're here for them for that. I think I'd also want to maybe figure out a way to maybe simmer down some of the political rhetoric. I think it's damaging and dangerous. You know, there's some recent, you know, we're coming out of COVID. I think we did a really good job during COVID. We were able to actually, we had specific clinics for some of our non-English speaking community. that we set up specifically for them, and worked with some of the community partners to get people in. When we did our community outreach for vaccines across the nation and across the state, as a whole, there was a lot of disparity, specifically between African Americans and white folks on getting their vaccine uptake. When we did our clinics, we had a 1-to-1 ratio.
Wow.
Because we took the clinics to the community.
Wow.
And we showed up. And then we came back and we did the second dose. And then we came back for another group. And so I think it helped build some of the trust, because we didn't ask them to come downtown. We didn't ask them to, mess with parking. We just said, we're going to come to you. Yeah. And we had a lot of support in a lot of our communities from the faith-based community, or the faith-based leaders, and that helped a lot. And so I think a bold plan, it's got to be something else that I would do. What else should I do? I just think it's all about the community.
It is.
What I would do? I would say a bold plan would be to have a full staff that can serve the community.
Listen, workforce development.
Yeah. And I think that, one of the things, and it's kind of like this, we're chasing our tail sometimes, is how do we get people in who want to stay? Because, public health, you're not gonna get rich. We know that, right? And so part of it is recruiting from our community, so people want to stay and serve the community. Yeah. So I think that would be a really nice, bold plan if I could get that. So we're kind of doing it.
You are.
Yeah, we're kind of doing it.
You are. So we're talking a little bit about workforce development, and I've had some other conversations where this has come up, and I know that your plan is specific to your health department, but I am a believer that things are transferable, right? If you're doing something really well, how can I translate that to engineering or maintenance or whatnot? Right. So what are some success and some things that you've done in developing your work? Because the heart of a lot of our issues are workforce, right? Getting people employed, having that retention, having the bodies that we need to do the work that our community needs to happen. So what are some lessons or some wins or, some insight that you can glean for other organizations that are working on these workforce development plans?
So we were very lucky through COVID when they recognized that there wasn't enough workforce. Particularly in response to COVID.
Yes.
The CDC released funding that was blanket funding that we could use for any workforce initiatives that we wanted. Okay. And it could be everything from staff incentives to hiring additional nurses. Oh, wow. So when we looked at what we needed, this was under the previous health commissioner, Jim Adams, we identified that we needed another epidemiologist. Okay. So when COVID hit, I was the director, and in my interview, I remember them saying, and I was an epi before, and they said, well, as a director, can you still do the epi work? Because, we all wear multiple hats.
Yes, yes.
And I was like, oh, I can until I can't. Not knowing.
I love that.
So that was in January of 2020, and then in March 2020, COVID hit, and I was like, oh my God, I can't. I did.
But you told them that.
Yeah, I did tell them that. So then we ended up hiring an epidemiologist, and we also hired a workforce development specialist. So I think the first key is somebody dedicated to the work. My workforce development specialist, she just told me this whole week she's barely in the office because she is out doing job fairs. Okay. She's out working with Tom Todd. She does some of the Tom Todd work. She works with several of the other educational services across the Stark Educational Partnership. And it's really just introducing the community to your space and your work. Yeah. A lot of people, to your point, I hire engineers. We have an air pollution control department. I need engineers for that. I hire nurses, dietitians, epidemiologists, environmental health specialists. And so I need all of those people to know that, or people who are interested in that work, that I'll hire you. Come in, you can serve the community. So that's one. And so she's out there and she's doing it for Canton City Public Health, but she's also doing it just for public health in general. So we do have 4 health departments in Stark County. And so one of the things that we've kind of offered to the other health departments is we're going to promote public health as a career option. And it's going to benefit everybody and anybody. Yeah. So that's one thing that's worked out really well for us is that. The other thing is looking at your job descriptions. So, for instance, our environmental health specialists that need that requirement of 30 semester hours of science. We would also require, they have to have a license through the Ohio Department of Health called a sanitarian and training license.
Okay.
All you have to do is submit your transcripts and you get the license. It's like an apprenticeship kind of thing.
Got it.
You don't have to sit for a test. You just have to have the qualifications. You get the training, the certificate, and then you have 2 to 3 years to do the training, and then you sit for a test.
Okay.
And we would advertise the positions, and we would get 0 applicants because no one knew what the SIT.
Exactly.
Nobody knew what to do or go. It was just a giant barrier. So we changed the job description and requirements and said you can apply for the job. You have to have a science degree still. That's a requirement. And then we'll help you get your SIT if we're interested in you. So basically we were able to, so we went from having 1 applicant to over 10.
Really?
And so we were able to interview, I think we interviewed, of the 10, we interviewed 9 of them, the last round of, and we hired 4 of them.
Wow.
Yes. So 2 of them had their SIT, and then 2 of them did not. And so we said, okay, we're interested in hiring you. Here's how you get your SIT. We helped them, and as soon as they got it, we took it to the board for hire.
Awesome.
So I think just thinking about what are the barriers and saying, okay, how do I remove these barriers?
Yeah.
My sanitarian, one of the gentlemen, and he'll probably, I didn't ask if I could talk about him, but I'm going to. He worked at a local grocery store in the bakery, and he put himself through school. He's from Canton. He got an environmental health degree because he wanted to be a health inspector because he saw him come through.
Yeah.
He saw him come through when they were, inspecting the bakery and inspecting the grocery store. And so we actually grabbed him. We didn't know him at the time, but when he was telling us the story, we're so excited to have him. So I just think that, when our staff go out, we always talk to people about the opportunity.
Yeah.
Anytime I hear about somebody who has a biology degree and they don't know what they want to do, I'm like, come sit and talk to me. Yeah.
Let's talk.
So I think workforce is really just about exposure.
Yep.
And getting people out there. And again, for us, we want to hire from our community.
Yeah.
I think there'll be longevity with the community. And the other thing that I've done, and I'm still working on it, it's a long process, but previously we never really had internally like paths to promotion.
Okay.
And so people would kind of get stuck. And then they would leave because they, and so we're working on, for several of our positions, having an opportunity where people can come in, kind of for the first 2 or 3 years, get trained, and then because the learning curve in most of our positions is about 18 months to 2 years.
Okay.
And then once you get to that point, then having an opportunity for a promotion once you're a little bit more independent.
Okay.
So that just helps support and give people something to look forward to and to strive for.
Yeah. You said so many great, like there's so many nuggets in there, right? I think key one is when we talk about the gentleman with the bakery, looking for candidates in unsuspecting places, right? You wouldn't think, but he's, like you said, he's seen these inspectors come through and he has interest in that. I think sometimes in our mind, we're focused on where we want to recruit at, right?
Right.
And then when you talk about having a person to do the work,
yes,
that is where we fall short, right? Because budgets are tight. We don't want to hire more people. We think we can't hire more people, so folks just wear 9 million hats. But you're right. I think that for organizations for our community as a whole that's talking about workforce development, we have to have somebody to do the work, somebody who's responsible and accountable for the work, because it just goes by the wayside.
And for me, with a data standpoint, I can show the return on investment of having
Absolutely.
her. Because our retention rates were low, right? And it's kind of hard during COVID because it was a really tough time for people. But, we want people to come in and stay. And if I invest in you for 9 months and then you leave, I have lost so much money.
Yeah.
So I can show, look, I'm going to have a full-time workforce development person. It's going to cost X amount of dollars, but here's how much I'm going to save.
Yeah.
And I don't remember the numbers now, but I remember when I was interviewing for the position, because I was an internal candidate, I was able to show the amount of money we were losing on quick exits.
Yeah.
And saying, okay, not only am I going to have to invest in this, but also when I come in, I'm going to have to look at the culture and find out what's happening. Like, why are people exiting? Because, government work used to be something that people would strive for, right? And especially, having that, if you had a servant mindset. And, I just want to make sure that when we get good people in, that we're able to retain them.
And I love how you keep referring back to relationship, because that's key in this work, whether we're in the health department or here at Beacon.
Right.
The relationships are critical.
Yep, 100%. 100%. You can't do it all.
Nope.
I know we want to, but we can't.
Yeah.
Yeah.
And you work on so many different things,
Mm-hmm.
right? So how do you measure success, of the lived experience of the community members or of your, your team that's out there? How are we measuring success?
I think it's interesting. I think in a lot of the work that we do, we look at the metrics, performance measures.
Mm-hmm.
Am I making a difference? What am I doing? How well am I doing it? And what difference does it make? And when I was in school, it was really focused on data. I would say the last few years, maybe more than the last few years, but we really started focusing on what's the community telling us, and what are the stories. So I think the data can tell us the what's happening, right? With like where and what. Right. But it's those anecdotal stories from the community that's telling us how we're going to fix it, where it actually lies deep into, So like one of the examples, and this is just an example with data, is when we run our STI data, the rates of chlamydia among women is so much higher than men.
Really?
It's because men don't get tested. So women carry the burden of the positives, and it looks like women have more chlamydia than men.
Right.
But women aren't getting chlamydia
without a man, right?
Yeah.
Right.
I mean, some could, but yeah. So you kind of have to look at the data and say, okay, what's going on here? And then we pull people in.
Yeah.
Kind of hear the story. One of the things that I just learned this week, and I'm excited to talk to some of our housing providers about it. And maybe this is common knowledge, but I didn't really think about this. With our SWAP program, which is our syringe exchange program, we have a lot of individuals who come in who are unhoused, or they're couch surfing or whatnot. And so we were asking them about, like, well, why don't you go to the shelters? Why don't you do, because Stark County is a housing first model. Okay. So you don't necessarily have to be in recovery to get housing. Okay. Well, again, social determinants, let's get you housed, and then we'll work through what you need to focus on. And the director that runs that program told me that they were talking about the housing situation, and they said that they don't seek housing in the summer because there's a limit on how long they could be in the shelter. So they save it for the winter.
Oh.
Right? So it's smart.
It's very smart.
But it looks like we have a larger homelessness problem during the summer because they're not necessarily going. And so that's a systemic It's a system problem.
It is.
So we need to look at that and say, okay, what is the barrier? Is it HUD funding? Is there a limitation?
Right.
How do we break this so that people aren't afraid to seek housing during the summer?
Right.
And are saving it for the winter. So that was something that was kind of recently brought up to me. So that's the kind of difference. That's the thing that I love. That's that theory versus practice.
Yes.
Like, here's what we have in theory, and it's great. But then when people actually use the system, this is what it looks like in practice, and then, we've got some holes and some gaps.
We do. Barriers, built-in barriers. I talk about this a lot. We have programming, we have services, and we think, why aren't people using it?
Right.
Well, it's a pain in the neck to navigate it. Yeah. So looking at and picking out. That's why storytelling is so important.
I agree. Yep, and you find that out, and you're like, well, if you're feeling this way, how many other people are feeling this way?
Yeah.
So one of the things too that just recently came up, and it's not an answer, but I'm really excited and proud of the city. But we, for those who don't know, our WIC and nursing services have been relocated temporarily to a building on Wirtz Avenue because our building on Market was going through a renovation, and so we just got the green light that our inspection went through, and that we will be moving back the week of October 13th.
Awesome.
And so we'll be open to the public. For those two services, we'll be back open to the public at the Market location on October 20th.
Okay.
Well, there's been chatter with the clients because the Wirtz building has way better parking than the Market building.
And it does.
It does, yes. It's a downtown building, and So
it does.
So my WIC director said, what are the chances that we designate some spots? So we have moms that come in for WIC, and they've got baby carriers and strollers, and some of them are pregnant women, and they're whatever trimester, and they have to park far away. And she's like, what are the chances that we can get some designated spots around our building for our moms and our families that have small kids? I was like, I don't know. It's a no unless you ask, right? So I asked, and the city loved the idea. So we'll have 4 spots around the Sears building that are dedicated to pregnant women, and families with small children. So it's not an answer.
It's a win, though.
It's a win, and hopefully it'll at least get people who need it a little bit closer. So take a little stress.
That's
off their visit to the health department.
To the health department.
Yeah.
All right, Amanda, we're moving into my miracle question. I always ask a miracle question. If you can remove one barrier, wake up tomorrow, poof, it's gone. What would that be, and how would it change the outcome of the work you're doing with the health department?
It's a great question. I think at this point, I'm going to say two.
Okay.
Okay. So the first barrier I would say is all of the federal chatter and discontent that is causing the community to be confused and scared.
Yeah.
It's not helping, and I don't know. I don't know what the end game is.
Right.
And I think that's a little bit scary. And then I think locally, I would like to continue to help. I would like to continue to build trust with the community. The communities that have been hurt by the government and public health in the past, including the communities that might be scared or confused. That would be probably my biggest, because I think we could do a lot of really good work if folks can trust that we're here for the right reasons. And so I'll continue to work on that.
Yeah. And those are barriers that we don't think about, right? Those external things like uncertainty and lacks of trust. That's great.
Yeah, I think, and I think, being, like I said, the people that work there are from here. Like they're local folks, and I think being from Canton, although I might not have the same experiences, I can at least recognize when someone says, oh, I grew up over by this park, or I went to this church, or that was my teacher, that I don't know their experiences, but I can relate to them because I know the area, and I know the spaces, and I've had similar experiences growing up. So, it's a nice place to be where I can connect with the community, and I just hope that can continue to grow.
Absolutely.
Yeah.
So, man, is there anything that I didn't ask you about, or I didn't talk about, or that we didn't cover that you would like our listeners to know?
The only thing that I would say is, as a health commissioner, one of my initiatives is, as we are able to bring funding in, when possible, I'm always looking to hold some of that money back for a grassroots or community-based organization. Okay. And so, we have deliverables a lot of times with the dollars, but we're trying to figure out, sometimes the people that need the services or whatever it is the most are the hardest to reach. Yeah. And I might not be, or my team might not be the best to reach them, but maybe Beacon is. Okay. And so we're trying to say, okay, if I'm going to get a grant for harm reduction, or if I'm going to get a grant for infant vitality or whatever, that I'm holding money back so I can partner with a community-based organization to help expand our reach. That's awesome. And help even, build those partnerships. So that's one of the things that I'm focused on doing. Some of the grants don't allow us to do it, but most of them do. Okay. And so that's one of the things that we've kind of started here in the last year.
That's awesome. Collaboration is essential. Yep. It takes a village.
Right. And sometimes some organizations aren't equipped to get a state or federal grant. Absolutely. And so let us help you. We can be the fiscal agent, we can help with reporting, we can help facilitate some of that. And again, from the anecdotal space, I might not know what's going on. Right. But you might, or another CBO might know what's going on. And we need that information so that we can partner together and
I love it.
And bring it in. So
I love it. That is a great note to end on. So Amanda, thank you for sitting with me.
Thank you, Doc.
The insight has been amazing. So thank you and keep up the great work.
Thank you. Well, thank you for doing this. I'm proud of you.
Thank you,
for pulling this together, and thanks for having me on.